you. My name is Schraag. I'm now adding a little bit of clinical aspects to the monitoring and the balance of using the monitor in the concept of anesthesia, what we heard so far. I'm a cardiothoracic anaesthetist, and initially I worked out pretty quickly that I can't use such assessments in cardiac surgery, so I moved to my other specialty and wanted to know whether there is a useful implication for actually running the patients in cardiothoracic, but also getting more proof of concept of anti-nociception monitoring. So I moved into the context of how well not just opioids but local anesthetics are working. You have been told about the various components of the NOL index, the various components that have different qualities, they have different sort of benefits, but they also are, each component of them is subject to interruption and artifacts. So you bear that in mind in the following presentation. The NOL scale has been defined very user-friendly because, as many of our indices that we use nowadays, it is in a scale starting about 100 and then ending at 0. However, it is not something which is probably kind of the end of the story, because we have now suggested so far that a NOL less than 25 suggests sufficient analgesia in the context of surgical stimulation. And remember what Don was saying is we have always considered anesthesia responses not just as a consequence of our drugs, but as a balance of the drugs that blunt surgical stimulation. It is an interesting graph I'm showing you now from that publication that has been already mentioned in the first talk about the study from Leiden, where they put the overall amount of in which nociception level range the patients actually were into a spectrogram. And the top level is, the top panel is the nociception level guided group, whereas the bottom one is the standard care group. Now, at the top one, you see that if you actually titrate towards a range of 25 to 10, it is possible to get a slightly lighter pattern, which is shown by highlighted by this slightly more bluish appearance, light bluish appearance at the top of the red. Whereas the lower pattern is probably the reason why these patients received more opioids, because by and large they had lower NOL levels. And whether that NOL level of 0 to 10 is of any relevance is probably up for discussion. Now, in thoracic anesthesia, we have various problems. We know it's a procedure that can actually end up, in a lot of patients, in chronic pain or chronic pain recurrence. You're also aware of those who perform thoracic anesthesia. There's an ongoing discussion and a lively discussion, what is the best local anesthetic technique? And there is a trend that the epidural, which was the gold standard so far, is being challenged by other techniques like paravertebral blocks. And as we enter this sort of opioid discussion here, we are aware of the limited effects that we have with opioids and the relatively well-documented side effects. So, but surgically we've moved on as well. We have now procedures that are less invasive, where the level and the quality of stimulation has changed. Video-assisted or robotic-assisted techniques have been introduced. And these are the sort of things I was talking about now. When I was preparing for this lecture, I was looking, is there anything already published on thoracic surgery using the NOL index? And there is indeed a study from Canada that has looked at the comparison of using epidurals versus non-epidurals in terms of the response to various stimuli. And this is the response panel against the skin incision. The skin incision is here at it's time 0. And the top panel here is a bit difficult to see, is the epidural group, and below that is the non-epidural group. And because there is huge variability there's a huge overlap, but there is a tendency, if you calculate the differential, that having a local anesthetic, the increase in the variation of the NOL is less than in the standard group, although there is a huge overlap. And so the question I had with us was, is there a possibility to document more objectively whether your local blocks are actually working? Why is that important? In clinical practice, local anesthetic techniques have long been used, published, compared, but if you look at the literature, there is very, very little standards by which you can actually derive whether the blocks in these groups have actually worked. Now, this is our practice here. In our center, we do about 600 VATS and RATS lung resections, and we do that by about 4 surgeons who have, amazingly, come across a fairly standardized technique meanwhile. In particular, because we spend about €1 million to buy this robot, and one of the selling points or buying points, it depends on which side of the purchase you are, was that it will create less painful stimulation, it's more precise, and therefore the leverage of the trocar is less, blah, 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 and the patient will go home quicker. So that is the proposal we need to support. Now, previously, the effectiveness of the paravertebral blocks were a bit patchy, to say the least. Now, this is our setup, and the patient, I don't know if you see, the patient is on the side, it's under this sort of little canopy and a plastic cover. His arm is on a wee up-sided gutter, and the question here was which side of the patient, which arm, which finger we should use the NOL. Remember, one of the quality that is being detected is movement, or movement acceleration, and quite often the arms are a bit subjected to inadequate movement, and therefore we were looking at which is the best. So we found out that actually the arm on the dependent side is less affected by these artifacts. With applying a standard protocol in thoracics, we're using intravenous anesthesia there. We recently moved to standardize the propofol element to a sort of basic feedback closed loop system. We use remifentanil that we titrate roughly between 3 and 3.5 nanogram per ml, not necessarily more. We use a low-dose ketamine infusion, and we use a paravertebral block that is being used with levobupivacaine. We give a bit of dexamethasone up front. We use non-steroidals if we can, and we have to paralyze these patients for robotic surgery quite well, so we have to use a reversal at the end, which is also monitored. Now, the problem with the paravertebral block is one thing. You probably, if you think back at your textbook knowledge, the classical approach of a paravertebral block is from the back, either by landmarks or with ultrasound. But at least in the UK, it has been established that anaesthetists have kind of moved back from that and let the surgeons do it when they have their scopes in the chest, and actually create a sort of paravertebral block that, in my view, can often be a sort of variable proximal intercostal block or anything, and therefore our approaches were quite inconsistent. But now the surgeons have started doing that fairly early in the case, and we can top them up, and we hopefully have more consistent results. Now, let's go into the matter now. This is a robotic robotic lobe resection of a patient, and it gives you the sort of time scale of the variation in the NOL value. And you can see that, for example, that on the left-hand side, intubation, especially with the double lumen tube, is still quite a noxious stimulus. And even though you give opioids, etc., this is pretty much almost an unbluntable stimulation. in the best of cases. You can see thereafter there is a bit of a lull when patients are positioned here. And then there's a first skin incision, and these trocars for the robotic procedure are inserted into the chest. And that again is a bit of a stimulation, as you can see, but not necessarily as Dan was saying, not necessarily as much a stimulus than the intubation. And then you can see the paravertebrals are inserted and they're topped up here at this point. And there onwards, you can see there's a fairly settled way of operation. And these robotic surgeries, this was a 200-minute operation, but some of them are actually much longer. And just to show you what I believe is quite a satisfactory course of, and that was replicated in the clinical appearance and in the sort of standard assessment, what you would normally do. Now, the following day, I did a video-assisted thoracic, so not a RATS case, just a standard RATS, and that is a similar procedure. That we had a bit of a problem here with that the signal was dropping out for a wee while, but by and large, you can see a similar case with a tendency of the, stimulation level a little bit more between, let's say, 10 and 15, maybe up to 20, 25 at some point. So it's a bit more variable, this sort of thing. So, and that gave me the sort of idea, why not study this in a prospective evaluation? That's what we're going to do in a couple of weeks starting. Again, 2 patients that we did recently. These are actually patients that I did back to back in theatres. And the top one is, again, a patient. You can see the typical pattern: intubation, no stimulation, trocar insertion, paravertebrals topped up, and then a fairly steady course. Now that was the typical thing here, and the NOL will just demonstrate that this is happening. This is where surgery actually starts, and then we hope that the recordings get more stable, and that was in keeping with the hemodynamics and with pretty much all the other documentation of the patients. However, there you could say at this point there is a bit of a discrepancy between the two, and indeed it was perceived with larger hemodynamic changes as well, and with the requirements of increasing the remifentanil, that there is inadequate analgesia in the bottom patient. So what was done, I asked the surgeon to re-site the paravertebral catheter, because it was quite clear it was leaking, it wasn't in the right place, and that was done. And thereafter you could see there's a similar pattern, with much less variability. Both patients actually had a fairly uneventful post-operative course. Both patients could be discharged in a reasonable time, and there was minimal analgesia requirements post-operatively. And the first and especially the second day was managed by mainly local anesthetic infusion. So that shows you the sort of intervention of a local anesthetic technique can be demonstrated in a change of pattern in the NOL index. Another thing which was said earlier on is the sort of heart rate as such. And then we're saying the heart rate is an indicator of stimulation, but is a very bad one, because it's very much variable, very much and is a small signal change. And this is just a reflection. This is the sort of scale spread out into intubation. So if you imagine you have your double lumen tube goes in at this point, you get a stimulus, probably because of the stimulus as such. And then you have a second peak, which is this, which comes a few seconds later, which I assume, looking at the data, comes from the heart rate variability component of the NOL. Now, but if you look at the same time at the heart rate as such, that is documented in the patient's recordings, you don't get the immediate heart rate change when you intubate, but you get it thereafter. So there is a bit of advantage to add more components into a nociception monitor than just looking at the heart rate. And if you are honest, if you look at the heart rate scale, the actual heart rate scale changes is minimal. These are the changes that you had on your anesthetic record system. And you would not probably notice that in response to a stimulation, because it will be amongst other variables and amongst the noise. So looking at hemodynamics in general, quite often we have to use vasoactive medications to support hemodynamics, etc., etc. And I just wanted to show you the difference between two types. The patient actually had a bit of a drop in blood pressure here, and my registrar gave a bit, had an intervention here, and he actually gave a small dose of ephedrine. So we know ephedrine is very good in this, and you can see the blood pressure, immediately responded. But what also responded is the heart rate, because the heart rate is pretty much, or ephedrine works as increasing cardiac output, mainly by the heart rate. And if you overlay the sort of NOL recordings at the same time, you can see that actually the NOL went up as the heart rate went up. So the NOL is very sensitive to actually pharmacologically induced changes in heart rate. Now, later in the case, similar things happened. You can see at the left-hand side of the recording here, the blood pressure kind of drifted down. So, and we thought, well, let's not give ephedrine, but let's give a vasoconstrictor. And we gave a bit of metraminol, which is a peripheral vasoconstrictor. And you can see the blood pressure came up nicely. But then if you look at the NOL changes, there weren't any, because the heart rate didn't change. And there was no necessary reflection of that being a nociceptive stimulus. It was a pure hypertensive element, which has been corrected in the sense. So my observations so far with the technique, it is very, very rapid. It is quick. It is a fast response signal. We do have, I must say, the odd dropout signal issues, especially if the patient is moving in these transition phases of induction and recovery. That may be just me using it the wrong way, I don't know. In my view, and we've done about 20 of these patients now in a case series, it does reflect the effectiveness of the paravertebral block, means the local anesthetic effect. And that is a potent suppression of the sympathetic nervous system. And it does detect incomplete analgesia, whether you would top that up with another dose of local anesthetics or resite a catheter, or indeed give more opioids. I think it does reflect that. What I'm a bit unclear is, to be honest, and we may discuss that here, is the range of 0 to 10, which apparently is, since it's not a well-defined area in the algorithm. And a lot of my patients do actually have indeed, during these cases, NOL indices of between 0 and 10, where I would otherwise say, well, they're perfectly well anesthetized. But whether, and in the absence of too much opioids, I can see the point. If you have, as you said, if you have this and you have too much opioids, you can actually reduce them and use this as a sort of opioid-sparing incentive. But in my patients, I wonder whether the sympathetic block in itself is just creating such a pattern. And that's why we've embarking on a study. We will just compare these in a prospective trial. We will also compare it with other nociceptive monitors, and we will look at what we see. Thanks very much for your attention. And I hope the NOL will hopefully be jumping the sort of movement that new technologies usually do. They go through a hype, and they're usually up there, down to a trough of disillusionment, and you would jump straight into this sort of plateau of productivity. All right? Thank you.